I wouldn't like you to leave that general chapter of the autonomic nervous system thinking everything's going to be cardiovascular, it's all about blood pressure and heart rate. You know, it's nearly true though, but not quite. Look, another big system we're going to like are those of the eye. I think one basis behind that eye section is the fact that for us in medicine, particularly in emergency room, in poison control centers, in toxicology cases, the eye can become a nice spot for us to note what drug a patient might have been under the influence of. Looking at pupil size in particular is quite relevant. Now first, what's the ANS to do with a pupil? Well, look, the pupil's purpose is to adjust the amount of light that hit the photoreceptors of the retina, making sure that they're not understimulated so that we miss information from our environment. Neither should they be overstimulated, then they would desensitize and we would be totally blind and not be able to integrate any information visually from that environment. So the pupil size is controlled very well by two sets of muscles. One set of muscle is actually a sphincter type of muscle, so it's circular. I'm making it in red here. And sphincter muscles, look at my hand, sphincter muscles, if I ask them to contract, squeak, I'm going to shrink the size of a pupil. So sphincter muscle contraction will result in pinpoint pupil. That is what we call miosis. So this would happen by stimulation of the sphincter muscle. Contrast. If I go right here, you see that there is another muscle that controls the actual eye. And this one, I'm going to paint it in purple. It is like the spokes of a wheel, and it's called the radial muscle. Now look at my hands. My fingers are the radial muscle, and in the middle is the pupil. If I contract the radial muscle, then obviously what I result in by stimulation of a radial muscle is dilated pupil and what we call mydriasis. So I have two muscles in my iris that control the size of a pupil. Sphincter muscle for miosis, radial muscle for mydriasis. I don't have to think about adjusting that pupil with a degree of ambient light. ANS does it for me. Make it logical. When do you think you want to have the maximum information visually from your environment? When you're sitting on a couch eating potato chips and watching TV? Or when you're about to have a flight, fright, or fight response because, I don't know, you have an alligator in your back alley. Whatever the case might be, flight, fright, and fight, I'm sure, is when I'm going to need dilated pupils. That means a radial muscle is going to be under sympathetic autonomic nervous system control. And to contract smooth muscle of the iris, there is no other better receptor than an alpha-1. Recall in your general principle and in biochemistry, it is GQ coupled. It will increase calcium inside the cell and cause contraction. If an alpha-1 receptor contracts the radial muscle to cause mydriasis, then a muscarinic receptor will be on the sphincter muscle to cause miosis. Endpoint from this, let me take another sheet. If I want to see miosis, it will happen with contraction of the sphincter muscle, which is under the influence of muscarinic receptors. Therefore, it would occur with muscarinic agonists. On the other hand, if I want mydriasis, dilated pupils, there is no doubt that this would happen when I'm going to see contraction of the radial muscle, and contraction of the radial muscle is under the control of alpha-1 receptors. Therefore, alpha-1 agonists are the ones that will result in mydriasis. Is it fair then to say that I have dual innervation for my pupil size regulation? You bet. In which case, there is another way of changing pupil size. Besides using those agonists, give me another way of getting miosis. If I want miosis, I could have also blocked the alpha-1 receptors. Conversely, if I wanted mydriasis, I could have also blocked muscarinic receptors. Essentially, what I'm saying is this. If I want to see meiosis, I can stimulate muscarinic receptors, or I can block the radial muscle. And if I block the radial muscle, all that's left for the eye to do is constriction of sphincter and meiosis. Conversely, if I want to see mydriasis, I can do it by stimulation of alpha-1 or by blockade of sphincter muscle. If I block the sphincter muscle, all I leave in the eye is sympathetic predominance, and mydriasis would follow. So as such, is it fair to say that when I see an actual pupil change in my patient, I can come up with at least 2 autonomic classes of drugs? Of course, it's telling you that you always have 2 choices when you're just looking at pupil changes. That's not good, because on the day of my exam, I bet you both choices are going to be available in your answers. So we need to find something else related to vision that will discriminate between the meiosis of a muscarinic agonist and that of an alpha blocker, or the mydriasis of an alpha-1 agonist or that of a muscarinic blocker. You know what that's going to be? It's going to be accommodation. Accommodation has nothing to do with your pupil. Accommodation has to do with the ciliary muscle. The ciliary muscle is a muscle that holds together with suspensory ligament the lens. I'm going to show you how it works. I'm going to take 2 papers right here that I have, and imagine this is your lens. Actually, you see it's a piece of your syllabus, but don't tell anyone. And as this is your lens, my fingers are actually the ciliary muscle, and what you're seeing on your diagram is exactly what I'm showing you right there. If I contract the ciliary muscle, look what happens. The lens changes shapes and it becomes more spherical. If I relax the ciliary muscle, it becomes flatter. Now, a lens is not supposed to be white like a sheet of paper unless you have cataracts, but overall a lens is like a window. If a window is nice and flat, you can see as far as infinity through that window. If that window is bowing and is more spherical, it's going to distort that vision. This is what our eye does to focus for near vision. To see what is close to your nose tip, you want ciliary muscle contraction, a more spherical lens, so that like this you can focus for near vision and have that accommodation reaction. Well, ciliary muscles only have muscarinic receptors. There is no alpha-1 receptor whatsoever participating in the process of accommodation. It's purely under parasympathetic control. Actually, in a way, it makes sense. If I was in flight, fright, or fight, I would not like my sympathetic nervous system to fix me in one way or the other. I want to still have the leeway of actually controlling my vision, either accommodating for what is close and then suddenly raising my head and wanting to run away. I want to see what's in the distance. So accommodation is purely under parasympathetic. In turn, it means for us, only muscarinic drugs will affect accommodation. Alpha-1 drugs can never affect the accommodation. I hope it's clear for you, because what will not be clear for your patient will be the fact that they have blurred vision when you use muscarinic drugs. Look, if I use a muscarinic agonist, then I'll have contraction of ciliary muscle, my lens will be more spherical, and I'll have a spasm of accommodation. It means now I'm focusing for near vision, for near objects. Of course, in that situation, it means I see clear what is in front of my nose, but everything in the distance is going to be totally blurry. On the other hand, if I block those muscarinic receptors, well, antagonizing these receptors is going to prevent the contraction of ciliary muscle and leave me with that normal flat lens. In this case, I cannot focus for near vision. What I'm seeing clear is what is in the distance. And clear in the distance means it's going to be blurry for close objects. Focusing for near vision means it's going to be blurry for distant object. So what should be the chief complaint of a muscarinic drug when it comes to accommodation? You are absolutely correct if you're thinking blurred vision. Blurred vision is a hallmark feature of a muscarinic drug. So look what we have in the margin at this point. If you see meiosis. You remember you have two possibilities. It's either muscarinic agonist or an alpha blocker. But if I tell you there is meiosis and accommodation for near vision, in other words, my patient sees clear what is in front of their nose tip, but sees blurry what is far in the distance, then I know this is a muscarinic stimulation. If there had been meiosis with no accommodation for near vision, then it would have been an alpha-1 antagonist. Look, other way round. If I see mydriasis and there is accommodation for far vision, in other words, the blurriness is for what is close to my nose tip. I can only see clear what is in the distance. It is what we call cycloplegia, as if you had the paralysis of the eye. It is the paralysis of accommodation. Anytime I fool around with accommodation, I must be a muscarinic drug. A muscarinic drug that dilates pupil, it's a muscarinic antagonist. Contrast, mydriasis with an alpha-1 agonist would have no effect on accommodation. There would be no cycloplegia. So if I go back now to summarize this on the actual little diagram we were building right here, how would you tell me that the meiosis I see is that of a muscarinic agonist or that of an alpha blocker? Well, let's see. Which one would not affect accommodation? The alpha blocker. So I would say here, no blurred vision. So I'm just going to put no blurred because I have no room on my page. And how would you know that the mydriasis is muscarinic blockers and not alpha-1 agonists? Well, with muscarinic blockers, there would have been blurred vision. With alpha-1 agonist, there would have been no blurred vision. So blurred vision, it's a muscarinic drug. If it's meiosis, it's a muscarinic agonist. If it's mydriasis, it's a muscarinic blocker. Well, this concludes our first chapter of the autonomic nervous system section.